that little notice probably. All right.
All right, welcome back, everyone. We are still talking about curricular bloat and unwarranted variability this afternoon, but we've brought together key stakeholders with more of a clinical lens than an academic administrative lens. So it is my pleasure to welcome the afternoon panel two, Bob Rowe, Rob Tillman, Brian Goodwin, Christin Lynch, Tracy Spitznagle, Karen Bock, and Chase Kuhn. As we mentioned earlier, you can look at their full bios on the web, and then I am posting to the chat just a brief bio. If you can read through it, it's all kind of mushed together, but hopefully as you guys answer questions, maybe share at least the first time you answer the lens that you're bringing to your response. And let's kick it off with a question that the whole group can answer, but I'll start with maybe Rob, and then, well, let's start with Rob. When you think of new graduates entering clinical practice, what are the current expectations that you have of new grads when they enter clinical practice?
I don't want to burn up too much time, but I've been listening yesterday and today about the dialogue here. Just a brief moment on my thoughts. A long time ago, I was trying to figure out what I wanted to do with my career because I knew I didn't know enough. I had a BS in physical therapy from Missouri, and got mentorship from folks like Dr. Linda Woodruff, Leon Anderson Jr., and really icons in the profession. They asked me what I wanted to do. I said, I really wanted to be really, really good, have a good set of clinical skills. And so the PhD model wasn't for me. So what I did was I did a residency with the Cerlandis Institute, which was with the same group that produced folks like Freddie Kaltenborn and Ola Grimsby and the like. And the key with that is, in that form of assessment, it's deeply rooted in neurophysiology, histology, and arthrokinematics. And with that solid platform, you can go anywhere with that as far as learning goes, and hands-on care and exercise training, which is the bedrock of our profession. What I look for with clinicians coming in the facility is not necessarily do they have the techniques, but do they have the foundations and the fund of knowledge and thought process? Do they understand anatomy, neurophysiology, histology, and arthrokinematics, so that they can manage the healing tissue matrix and apply and develop skills that will progress to being able to perform manipulations and things like that safely. When I trained in my residency for 4 years, we didn't learn how to manipulate until deep into the second year. So just a good core foundation of core sciences and some clinical skills like differential neurological evaluation. A question like, can you differentiate between a C8 radiculopathy and an ulnar nerve lesion? Things like that. So that's what I like to see in a student, that they have a good core of scientific foundation.
Thank you very much. Karen, how would you answer that question? What do you expect of the new graduate entering clinical practice?
My lens is a little bit different. I was a SCCE for 20 years in a level 1 trauma hospital. I've transitioned now into part-time faculty working on my PhD, but I still am really interested in the academic clinical partnership and how we have CIs ready to be mentors to our graduates who, well, before they're graduates, when they're in the clinic. But when a student's in the clinic, the thing that I really wanted was just someone who wanted to learn. I didn't necessarily need them. They need to have a baseline knowledge, but I knew they were going to go from my clinical to another clinical, and they were going to be exposed to a different set of patients and a different mentor with a different lens on what that therapy should look like. And I wanted them to be open to that. I wanted them to be open to learning. And I think it really will work well with our drive towards competency-based education and developing. I really am excited about master adaptive learning and think that that's all part of what clinicians are already looking for. We already want people who want to learn, and we want students who want to just be sponges and absorb, but we don't mind them coming in with a high level of knowledge. I don't know. I've been thinking about that as I've listened to the discussions and about preparing students beyond entry level in our DPT curriculum versus gaining that knowledge, and maybe more like Rob is saying, in a specialized residency later. It's interesting lens to look at, but I think just being open to learning is the main thing.
Great. I'm going to next call on Bob and then Tracy. And it's still the same question, what are the expectations of a new graduate entering clinical practice? But maybe also elaborate with regards to general skills versus specialized skills. Are those valued in a new graduate? Because you both have experience with residency fellowship education as well, and may make a distinction between higher levels of education and the new grad. Let's start with Bob.
Thank you very much. So I think, we would look for people who are very open to mentoring and Trace, Karen said this, people who are open-minded and, people who really essentially following, without Rob saying this, I mean, what he was talking about was, the search for professional development and growth. And, that's, I think at a more global sense, that's what, I think is really important and what we like to see in students, that, that commitment to lifelong learning and, the commitment to the profession and the commitment to the patient. And those are the things that I would, if we're talking at a more global level, those are the things that I'm looking for, that, that the patient is the center of the universe. And at that moment in time, they're the most important thing that's happening. And that they're also considering, what is it that what do they need to do to get better? Because obviously every one of us can get better and continue growing and developing our skills. And so, and for somebody who's younger, they have more opportunities to get better than others. And so I'm looking for somebody who's really actively considering how to do that. And I heard some other people talk about, post-professional, what people should do and what shouldn't they do. And, the reality is people do nothing, at the end of the day. I mean, very few people amongst our colleagues, they graduate and they go do the minimum. And, if you're doing the minimum, then you're falling way behind. You do essentially what your licensure requires you to do. And I'm obviously not talking about the people in this room and the people that we hang out with, but I'm talking about the masses, the critical mass of clinicians that are out there. And if you're not aware of that, then you got to climb out from under the rock you live under, because it's the reality that, the vast majority of our colleagues, just if you have to do 12 hours a year, they do 12 hours a year to get their license. And, if you look at the amount of information that's coming out, in terms of healthcare, you're not keeping up and you're falling behind, and you're going to become irrelevant. And so that commitment to professional development and growth, I think, is critical for that individual. It's critical for that individual's patients, and it's critical for the profession. It's critical for us, because otherwise they drag us down, because we lose validity and credibility, because they're harming us by their ineptness. So thanks.
Thank you. Tracy, still again, new graduate expectations of new grads, and maybe you can also add a layer of how you think those expectations may differ depending on different practice settings, and whether or not those expectations are being met in some settings and not others.
So I run a women's health residency, so that's the lens for which I'm kind of speaking from. And I also sit within our curriculum renewal on a thread team called CSE, which is Clinicians Scholar Educator. So I have kind of this dual role where I'm looking back and looking forward, and trying to envision how we're preparing our learners for specialty education. So I have kind of two perspectives. For the graduate that's coming out, if I was going to sit and interview someone for my residency, I would be looking for passion, an understanding of the basic components of the movement system and how you utilize movement within your practice. I would be really interested in understanding that they've explored enough about the specialty area, that they understand what they're getting themselves into, so that they have some kind of CV or dossier or building block towards their understanding that they're choosing something that they're not going to get halfway through and give up on me because this is not for me, ma'am. So that's a really kind of important piece that I really need to understand, that they understand what they're signing up for. And communication skills are paramount to being able to communicate their needs, be able to communicate with the patient, be able to work on that ability to negotiate, because we're working in a big, busy medical center. I'm also looking for change agents. So I've used my residency to drive programmatic change across our medical center and been able to do things like implement inpatient service lines related to C-sections that wouldn't have happened if it wasn't because of a residency project that was passion driven by one of the residents who took on the charge of developing the educational program. So it's kind of a diverse set of skills that I'm looking for. But the passion probably is the one that's key, that if they are really interested in what they're doing, they easily can go above and beyond in the area that they're interested in.
Excellent. Thank you. Chase, Brian, and Christin, you guys are earlier in your careers. Christin, you're in a novel 4-year hybrid program, and Chase and Brian are new grads or new to the profession. How is your perspective different in terms of what you think the expectations are of a new grad in entering clinical practice, and how that might differ from setting to setting? Let's start with Chase.
Sorry, I was headset muted. Thank you. I'm a orthopedic resident at Ohio State, and I have to be careful. My DPT program director is on this call, but that won't hold me back. I think that just kind of when we look at entering clinical practice, I think that the setting that you go to, at least in my experience and on my clinical rotations, kind of prior to graduation, it is different, the expectations. I think that even if you look at the onboarding process for a lot of clinics. So for instance, when I was in my inpatient neuro and kind of got a sense for what the new hires there were going through in terms of orientation, not only with just the documentation system and insurance and, you know, the how we do things here type stuff. It was a lot of kind of that content driven, like, let's make sure that this new hire knows what they have to do to be safe. And so I think there's a little bit of solace in knowing that depending on the setting that you go into and the real or perceived kind of acuity needs of the patients in that setting, I think that there is a difference in the expectations. For instance, when I started my residency, and I'm in outpatient orthopedics, I started seeing patients kind of the start of my second week, and it was just kind of expected that I would know, you know, how to do and interact and be safe with patients. But then on my acute care rotation, I know that they went through kind of like a 3-month orientation where you had somebody kind of holding your hand for the different units that you were on. And even then you had kind of a more in-depth if you were going to be working somewhere like an intensive care unit. So I think that the expectations of entering that kind of first job post-graduation are different. And I think that employers recognize that for, you know, their stakes and the liability of things. And so they have started and have been implementing things to bridge whatever real or perceived gap is there.
Thank you for that. How about Brian?
I graduated about 8 months ago, so that's the lens I'm coming in at. And so kind of going off what Karen and Chase and pretty much all the other panelists have said, the main thing that I found being a new grad that employers wanted was just that willingness to learn. and the openness to understand that you don't know everything when you graduate from your PT program. And I think the program that I was a part of did a pretty good job at kind of instilling that in us, to know that the learning doesn't necessarily stop when you get the degree. And so the employer that I'm with now, I'm in the outpatient sports kind of ortho realm. And so they were pretty heavy on giving that onboarding, but also implementing mentor slots. So that way it's been helpful to kind of not want to fall back into, like Bob said, that just run of the mill, get the paycheck, see the patients, get to the weekend. And so I think the expectation going forward now is just to keep growing the profession, but also keeping that willingness to learn in the new grads and in the people that the clinics are trying to hire.
Great. And last but not least, can we hear from Christin?
Hello, can you all hear me? Yes, okay, cool. So I actually graduate in 27 days. So I'm a 4th year DPT student with a hybrid program, and I'm in my 3rd clinical rotation, which is pelvic health actually. So my only little key thought on this, just because I still am a student, is as a student, we don't know what we don't know, right? So your clinicals are such an important part, because I thought, oh, I think pelvic health would be good. I'm a very manual therapist. I'm lymphedema certified already. I was doing that prior to school. But had I not gone through this rotation, I don't think I would have seeked it out further. So that's why like clinicals are so important, and also getting that education out there for the students, what all these specialties actually entail, in order to boost that want to do more. Because yes, I do feel like a lot of my classmates, they're going to just go, I'm just going to do sports therapy or just orthopedic, but there's so many specialties out there that are needed, specifically pelvic health and lymphedema. And, if you don't get the opportunity to experience it, then it's so sad, because then we're just going to continue to have limited clinicians in those specialties. So I hope that kind of related to that, but sorry.
No, thank you for sharing that perspective. So just to pull together some of the things I'm hearing, I heard, the importance of some foundational knowledge from Rob, and communication skills. And many of you spoke about the eagerness to learn, willingness to grow, being passionate. My next question, and this is for all of you, and we'll start with Bob this time. How well are the students and graduates these days prepared for these expectations that you have all just mentioned? How is the variability in their preparation impacting preparedness? Bob.
Yeah, thank you, Laurel. That's such a hard question, because it's hard to be politically correct and be able to answer that. And because if it depends on what the program, it goes back to everything we've talked about, like what is entry level? And I know that's one of the questions that we'll talk about here, but what is the program's goals, and what are so that's complex, and so are the students prepared to do what the program prepared them to do? In many cases, yes. I think many programs do a really good job of preparing students to meet CAPT criteria and to pass the NPTE. So if that's the goal, then everybody's doing a great job. But if the goal is to create a workforce of individuals where people are coming in and successfully managing patients, then we're failing miserably, because they don't have those skills, not to treat the full spectrum of patients that they're typically seeing within their setting. And I'm not talking about all settings, I'm just talking about their specialty setting, because that's most people are most students are graduating and going into a specialty area of practice right now. So even within that specialty area of practice, they don't have the skills, and not only do they not have the clinical skills, they don't have the what we would refer to as the behavioral skills to really be successful with managing that. And I can't wait for the question of entry level, because I'm all over it, and I have an answer for that one. So,
but I want to follow up with you though, because the earlier question is, what are your expectations of new grads? And the focus was on passion and eagerness to learn.
yeah.
Is that expectation being met, or are you revising your expectation to say that you expect graduates to be able to clinically manage the full spectrum of patients in a particular area? Or are expectations based on what's actually being produced and not where we really want to see things? I just asked 3 versions of that. But so earlier you wanted passion and eagerness to learn. Are the programs meeting that expectation?
Those are behavioral aspects, and I don't know how much programs can, I think programs can influence that somewhat, but I think a lot of that is naturally instilled within the people. And I think that goes back to, are we selecting the right people in the first place? And I did at ELC, I did an Ignite talk on that I think with not always accepting the best people into the programs to begin with, because we're accepting the 4.0s, these people, because we need to make sure that we look good, because we have to have high graduation rates, and we have to have people that pass the NPTE. And the academicians always get angry when I say that, but it's the truth. I mean, whatever. You can get mad at me, but it's still, at the end of the day, it's the truth. Okay. So I think we should be looking for, yes, of course, you need to have people that are going to go through the program, be successful, graduate, pass the NPTE. Yes, absolutely. But probably as important, you need to find people that have passion, that have motivation, that have curiosity, that have grit, that have all of those things that aren't necessarily part of every admissions process right now. So I'm not sure that I answered your question, but I think that's a whole nother ball game in terms of where we're failing, is not with how we're producing them, but how we're accepting them in the first place.
Thank you for that elaboration. Same question for others. Are the programs preparing students? I think Tracy has her hand up, and then I will say also, political correctness is not a criteria for your response. It is okay to engage in healthy debate and disagree with each other. That's what this is the Disruptive Innovation Summit. So that's okay to be disruptive. We'll be kind to each other, focus on ideas and not people, but it's okay for us not to agree. So go for it. Tracy, your turn.
So I guess from my perspective, what we're trying to do to meet the needs of the diversity of the learners, and that's diversity in their levels of interest, diversity in their abilities, is to allow as much choice as possible so that they can explore areas as they get to the last year and a half of their curriculum. The choice is going up for things that they can focus in, and still have base expectations that they will do things like a standard exam, and that there will be standardized things that every student will be required to do, but then it'll allow flexibility so that for those who need a learning environment for some of their last semester activities, that they can tailor it to the things that they're interested in, which is then will drive them hopefully to be a master adaptive learner within the environment for which that they're trying to move out to. I feel like if you're interested in pediatrics, you have to have some exposure to peds before you leave the curriculum, or you won't find a job anywhere, because they're looking. I think it's the same with the specialty required to work in an ICU is an excellent example that was brought up by Chase. And I think that having exposure to the environment and understanding what the skills are that are needed is an important piece. And that it's the onus on us as the educators to try to create that curriculum that integrates the cases in a way that allows the students to at least get exposed to more complexity. The complexity is one of the things that is difficult for a new graduate. And so I feel like that's a piece that we still need to work on, is how to teach outside of our silos and drive that complexity within the cases.
Thank you, Tracy. Karen, would you like to comment on how the variability in PT prep is impacting our ability to prepare graduates for entry-level practice?
I'd be happy to. I don't know. I'm not an employer necessarily, but I was picturing, as Tracy was speaking about, exposing students to the specialty areas and then thinking about the pushback. This is my devil's advocate opinion here of the CIs in those positions, and what the CIs would tell me if I was trying to put a student who was appropriately prepared, maybe even passionate, wanting to learn. But I'm not sure, again, that our healthcare environment is going to support that. We need to work on that. I'm not saying I don't think that shouldn't be worked on, but there's a lot of barriers from a productivity, from a resource standpoint, from a burnout standpoint of my CIs, that I don't think that unless they are a passionate teacher, they will readily embrace all of that exposure and all of their specialties. I'm a lymphedema wound care therapist. I loved having students who were interested in that on rotations with me. That was great, but I enjoy that teaching aspect. I had other therapists who it was a struggle. So I don't know. I think there's some barriers there that we need to keep in mind, and how we're going to address those. Not that it shouldn't be done, but we need to be careful with how we do it, perhaps.
Thank you for that. Rob, I see your hand up, and we can also move into the question of what is entry level when combining, asking whether or not students are prepared.
Is that a curveball?
It's yes.
I'm good. The thing is, if we look at our profession as we try to become more relevant, I think that's what we're talking about in the keynote last night, and some of the things that were presented today, and Ellen's comments, the lady from Delaware, and a few other folks, is how do we set the foundation for our profession to be relevant, effective attainers of outcomes that help improve function and that improve the value of our profession in its niche in society. And I think we're asking a bit much out of PT school the way that it stands now. I don't see that much of a difference in the time curriculum. I got a BS degree and then served a 4-year residency after that to attain my competencies, versus the 3-year program now. The difference is the degree status that's delivered now. And I'll warn us again, Carter G. Woodson, who is the developer of Black History Week, then Black History Month, wrote a book called The Miseducation of the Negro, to where if you chase a title and don't chase competencies or create an ability to produce a product that society is willing to pay for, we may be going down the wrong road. So relevance is the currency, because he was worried about the African-American community being irrelevant. So when we talk in the academy, I'm president of the American Academy of Physical Therapy, but relevance is imperative. And how do we earn it? By getting outcomes and showing competencies and being the evaluators going in. I don't think that we can get students proficient across the board at that in every setting. With a recent graduate, they don't have their own caseload. I've got 7 facilities now. They don't have their own caseload for about 6 months. I've got to eat that. But I want to be able to replicate the expected product of evaluation and treatment for musculoskeletal disorders that the communities that I serve have. So I'm not disappointed about the level of expertise that these students have, because our model is mirroring the medical model more and more as we go forward. Is they come out of school with an MD degree, and then they go out in the world and they learn what they need to know to occupy their niche. So I think that there's going to have to be some give for us to get to where we need to be with some of the clinical rotations, maybe having some hybrid programs with some of the fellowship and residency programs, creating a special certification program for young folks in their last portion of their formal education, so they're more game ready to participate and have a skill set that really lends them to be able to see a decent caseload. Because right now, I haven't seen a recent graduate that can walk into one of my facilities and take on a caseload and produce the clinical product that I'm going to need to see to feel comfortable with them.
So I love that you're also not just talking about where we are, but what's realistic. And Bob, you wanted to address the question about what's entry level, but add in the practicalities of what it would take to achieve your definition of entry level as well.
Thanks, Laurel. So, in my world, it's essentially what Rob's talking about. It's, that the individual is able to, when they enter the workforce, they can provide the level of care that assists the patient with attaining their highest level of function. And, and what we see today is that the patient attains the level of function that the therapist is qualified to perform. And that's backwards. And that's not helpful to the patient. So I don't understand, as healthcare providers, as human beings, how is that okay? How can we look ourselves in the mirror and feel good about that? And say, well, that's fine. We can just keep producing these people, these graduates, and let them be adequate providers of care, which is what Rob's talking about, which I completely 100% agree with. And then, but how does that help us? How does that help those patients? Living in Florida, I get a lot of, and I have a pretty good network of people. And so I get a lot of phone calls, a lot of texts, a lot of emails from people that are wanting to either refer patients because of snowbirds. So, different directions. So I get, people wanting to refer patients down here or refer patients that were down here back up north. And so I get a lot of those messages. And you know what people don't ever say? They don't ever say, hey, can you recommend an average PT? You know what they always say? Hey, I know you know great people. Can you recommend a great PT? And because that's what they want for their patients. That's what they want for their family. Okay. But on a regular basis, we're okay as an entity, as a society here, we're okay with putting a group, big masses of people out that are providing adequate care to patients. And I'm sorry, but I'm not okay with that. And you said, what's the practical answer? And the practical answer is that they don't enter the workforce immediately upon graduation from PT school, that there's another step that they follow, just like medicine. And that's what Ellen was talking about earlier. And that's what so many other groups have talked about, is that the next step is that they go into residency and they learn how to do what they really need to do to practice within that specialty setting, that where they're going to, live for the, for possibly the rest of their careers. And, that's the practical answer of what has to happen, and the body of knowledge now is absolutely sufficient and quite honestly demands that we do this. So thanks, Laurel.
Thank you. So Chase, I know you are in a residency program, but I'm going to go to Christin with this question first. What goes into your mind when considering what that next step might look like? When you're in a really rigorous, full program, are you left feeling curious to learn more? Are you overwhelmed, kind of feeling full and not really wanting to do further learning? As Bob said, many PT graduates don't take that next step to do more. Somewhere in between, what are some of the variables impacting how eager you are to advance education beyond the entry-level degree? starting with Christin.
I'm sorry, my internet was kind of cutting in and out, so I didn't know for sure if it was to me. With the thought of like, my program is 4 years, so I am at my max. I have gone through a lot of health issues this last year during my clinicals. My kids, I have kids, I have a husband. Like, it has been very difficult to make it through these 4 years. Not getting paid, not, like dealing with all the stressors. So my program, definitely, I left that going into clinicals feeling very bloated. I felt that I had all this unnecessary information because then when I went into my clinicals, I felt like I learned so much in my clinicals that either I was introduced to. So I feel like I was introduced to a lot, which is good. And then I was able to really hone in on some of those. My first one was long-term acute care. I was so nervous for that rotation. It was my first one, but it was the best. Like, I'm looking to maybe go work there actually. Like, I loved it. But I did not take what I learned in cardio pulm into that rotation, unfortunately, because it was such a little layer of what I learned. And it was so stressful learning it that I felt like I learned more just hands-on doing it there. And then of course the clinical instructor, I think, makes the biggest impact on your experience. If they love what they do, you're gonna enjoy it as a student. And then even the one I'm in now, the pelvic health, like, we learned obviously just the very basic. You're not going to learn internal work during your PT program, but not even just the internal treatment and assessment, but just everything else, how it relates to that. I feel like I've learned more in these last 9 weeks than I did in 3 years of school, just related to that specialty. Obviously, it's a specialty. But no, I definitely left the didactic part of my program feeling way overwhelmed. And then the clinicals, now I feel like I want to learn more. So I'm kind of getting both, which I find awesome. I also feel that a lot of my classmates, they had a lot of clinical experience already. So a lot of them are just there to get their degree, which is very unfortunate. Getting back to kind of that grid, I just want to mention on this is, like, I am a very non-traditional student. I'm in my 30s. I have 2 kids. I was working. That's why I chose my program, because it allowed me to take care of my family at the same time. And I loved that aspect of it. But I don't see how, like, cutting programs in half, well, I find that kind of offensive. Like, kind of going back to, like, how are you gonna throw all the information into a student in 2.5 years and do their clinical? I already feel bloated, and I had my program a little expanded out, so I can only imagine what's going to happen if we. So yeah, I hope that answers my perspective.
I think it's really important to have that perspective as part of the conversation. Bob, what are your thoughts on how eager students are, or new grads are, to learn more, given, how overwhelming their current curriculums may feel, including their clinical experiences? Or for you personally? I'm sorry, Bob. I didn't mean to say Bob.
Yeah.
I'm so sorry. I meant to say Brian. I apologize. Brian. I'm looking right at Brian. Can't you tell? My apologies, Brian.
Yeah, so I think kind of going off what Christin said too, I think in PT school, and granted, COVID hit first year PT school for me. So I think that period of PT school was more overwhelming, just because schools themselves were like, how do we transform this without making people fall behind? So I was very lucky to have like clinicals that were in settings that I was interested in and trying to decide between, which was like military and sports. And I was lucky to have CIs that were very passionate. So I think I left PT school, both the didactic portion and the clinical portion, wanting to learn more. Whereas I know I had classmates that had either CIs that weren't as interested, or clinical experiences that didn't go the way they had hoped. That can kind of put a wrench in some of their plans, or even just their thoughts about different settings. But it's almost been harder, I feel like, in the workforce to keep that drive just because I'm in an outpatient hospital system. So kind of going off of something that someone said earlier in terms of like the productivity, different standards that you're trying to meet for a clinic based, and then trying to keep that balance with your, your work-life balance while doing that continued education that costs money while you're also trying to pay loans and like all these things that add up that you have to keep up with as a person, not as just a physical therapist. And so I feel like it's almost some of those outside barriers that are inflicting more on physical therapists than maybe their drive. Like they can have that drive and that passion, but if they don't have the means or don't have the time, just whatever's going on in their life too, that can almost put more of a wrench in their plans, which again, it takes the grit and some of that as well. So it does fall back on that person, but I think it can definitely impact it.
Brian, thank you for mentioning work-life balance and the cost of pursuing residency education. It's not just a matter of whether people are eager to learn more that makes the difference. There are a lot of other factors that may go into whether or not someone pursues a residency program. But Chase, you did pursue a residency program. Maybe you can tell us more about your eagerness to learn more. What was before choosing the residency, did you feel your education was adequate? Did you feel prepared to enter the workforce, or was this an essential piece for being the kind of practitioner that you wanted to be?
Yeah, so I think that's a really good question. I think everyone ultimately ends up choosing to do a residency for different reasons, right? It's a multifactorial thing. Ultimately, I chose to do a residency because I felt like I didn't do well enough in this area of physical therapy practice for my own kind of like peace of mind that I wanted to be better at it. And the way that our program is set up, we're really in the DPT, we're really encouraged kind of to find the area that you're interested in via testing the waters kind of everywhere, that broad approach, have a neuro rotation, have an acute care rotation. We start everyone with their outpatient orthopedics in first year. And so I did my ortho rotation as my very first one at the end of first year, where I'm trying to cram the most information into my head. And kind of at the end of it, I was like, man, that was overwhelming. I don't feel like I did very well. I still have a lot to learn. And so kind of as I went through my other rotations, I was feeling more and more confident about those areas. And so when it came time to start thinking about like, what are these first steps after graduation going to be for me? I really felt kind of the opposite of what Christin is experiencing, where I felt like there was so much more for me to learn to get to where I felt competent, that I wanted that kind of mandatory mentorship, that residency kind of guided practice betterment. And as I think about that, and I think about some experiences of students that I met through kind of my involvement with the APTA, and Brian brought up the pandemic. Like, there is, I think, a massive variability in the preparation for students and how they feel. I talked to a couple students that I think largely because of the pandemic, their clinical opportunities were limited, and that they had 3 or 4 orthopedic clinical rotations and no neuro, no acute care. But then kind of as I'm hearing Bob and Robert talk about, wanting these individuals who are, specialized, or that's the way our education is kind of focused, and getting somebody to be competent at their chosen area of practice, would we be better served by having a student who's gone through 4 orthopedic rotations, so that by the time they graduate, they're ready to like enter that workforce and be good at it? Or is it better to have, the breadth of experience of acute care and neuro and cardiopulm and all of these things, knowing that they might not be as entry level ready as somebody who had more experience there? And I think we could debate that back and forth for a while, but I know that individual knew that that's what they wanted to do. And a lot of kind of what we hear those first couple semesters is like, oh, we make you do all of these rotations because you never know what you're going to be interested in. But if somebody knows what they're interested in and they're ready to get to that entry level, like high practicing, good at their job thing, and we're not supporting that from the curriculum from a clinical education standpoint, is there a way to challenge kind of this model, at least the one that I've been exposed to through my education?
Thank you. I think there will be people in this audience that may have opinions on that. Very good perspective. I'm going to throw this next question to Karen, because with our discussion around curricular bloat and unwarranted variability, something was mentioned this morning about marketability for clinics when people graduate, how to make a program distinctive. Even getting clinical placements can be a challenge for certain programs. So you want your students to be the ones that clinical sites want to take as well. So when you're thinking about students and their level of preparation from their institutions, what are the attributes that are desired in students by the clinical instructors? Like, what sets a clinical student apart from another student?
That's a good question. And it's interesting. We tend to all get comfortable maybe with the programs that we use, we interact with the most as clinical sites, I would say, or even the academic programs that we interact with the most. And so we kind of honestly know what we're getting is what a SCCE would tell you. I take students from that school because I know what I'm getting. I know the skill set that they're going to have. They're going to be strong in orthopedics, or they're going to be strong in neuro, but they'll be good enough in these other areas that it'll be fine. And so, at the end of the day, I think all clinical sites are looking for students who are, it's not some wild and crazy thing. They want students who are punctual. They want students who are going to be willing to learn, and they want students who are going to be open to, if this CI has a particular approach to low back pain, we don't, everybody wants students who sit there and value that particular CI's view and are able to articulate, well, this is how I did it in school, and so this is how I would approach it, and then be able to dialogue almost like a peer at that point. How would you do this, and how could I do it from my perspective? I mean, that's what CIs want. We want students who can dialogue at almost a professional level, even though they're a student, which is a big ask, right? And not come in with this preset notion of everything they told me at school was right. So I think that would be the biggest piece of that, is that as a student comes in, yes, I've got this background knowledge, this is how they showed me, but I'm willing to listen to how you're going to approach this. And what I tell students a lot is, if it doesn't match what you think is right, make sure it's safe, and then you can change that when you go into practice. But your job now is to listen to how this clinical instructor is telling you how to do this. I always relate it back to coaching sports. There's a million different ways to coach a batter and hitting, and you have to figure out which of those pieces make sense to you. And it's a big acronym. It's a big comparison, but it's kind of similar. As long as you're coming and willing to have an open mind. Again, I think I've said that more than once now. That's what we're looking for. The ones who don't, we don't ask those schools back. We don't look to hire those new grads. If they come in with that attitude, I mean, the student program I ran, that was a whole reason, was recruitment. We wanted those students back into clinic. Again, the onboarding is cut in half because I've already onboarded them once. I already know what I'm getting, so to speak, from a clinical skills standpoint. So that's how clinics are going to look at these. They're going to look at, if I can get the student in here, then I'm making that onboarding smaller. I'm making that time of them being less productive smaller, in my opinion. I don't know if, like I said, Rob and Bob are better. They are hiring people like that, but from the clinic. But yeah,
Rob, would you like to elaborate or take your own twist on the question?
Yeah,
Well,
Interested
can
to
you,
hear your perspective.
there was a lot packed into the answer. So can we go back to the core question?
Well, I was just asking about the attributes
Attributes.
desired by clinical instructors in the students.
Yeah. I thought about some specific scenarios. I've been, I've taught a bunch of residencies in a bunch of different states, and Bob Rowe was one of our students back when we both had hair, and I thought I was better looking than I am right now. But but there was a specific school that had this person that was a kind of a guru in orthopedics that didn't serve a residency or anything, but their students had bought into this person's philosophy of treating spine. And of course, I had my own ideas about it in defending my work internationally on differential diagnosis of lumbar spine and sacroiliac joints. So every time a student would come from that university, it was a battle. At some point, I would even hide from them and have someone else in the facility go ahead and be their clinical instructor, and they'd wait for me to come out of a room or get off the road and come in and challenge me. And I just and the problem is that their theory wasn't supported in the core sciences of neurophysiology, histology, and arthrokinematics, so we couldn't unpack it to have a logical discussion. When students show up with beliefs and techniques and have it to be their religion, it is an impossible scenario. That just like Karen was saying, as a matter of fact, I hadn't taken a student from that school in 20 years because of that. It's like, I'm not going to bother, because it became this turf war battle type thing that I just wasn't willing to participate in. So just, again, open-mindedness, willingness to learn. What I tell a lot of the therapists, we've got 7 offices now, but if somebody can present a better way of doing it than the core way, then we'll change the whole company. As long as it makes sense and the outcomes are there. There are nuances that can be added to things, but there's got to be a core bedrock of communication standards that we have in our profession. And I warn people against using jargon like upslips, downslips, inflares, and outflares. Orthopedic surgeons don't know what that means, but they do understand load sensitivities in connective tissue and hypermobility and movement around less than perfect physiological axis. But we're growing as a profession, and we need to be patient with ourselves. But we certainly need to stay away from the guru system of, I'm doing it this way because this person taught me how to do it.
Thank you. That sounds like that may be part of the unwarranted variability that may be out there in some of the programs. This was not in our pre-list of questions that was out there, but for the folks that are here in this panel with a more clinical perspective, what do you see as some of the things that maybe could come out of programs that need to get rid of some bloat to get us moving on the path that you think will be more effective? And I'll raise a finger and I'll call on you if you have thoughts on this. Tracy.
Well, I guess the first thing that comes to my mind is that as a graduating physical therapy student, they just have to have a standard exam for which they know the key components of a standard exam. And they need to understand all of the safety parameters for which someone moves. So from a cardiopulmonary perspective. So it's that safety with movement, and then the key components of a movement assessment of sorts. That's really, really important. If we could just have, as a profession, a base standard exam for which we all felt like we could come wrap our brains around, I think it would be really, really helpful, because that way each clinic site could then understand what is coming in the door, regardless of the institution for where they're coming from.
Other thoughts on recommendations to get rid of some of the bloat? What's in the curriculums that's muddying the waters for people entering our profession?
So,
Bob.
So Laurel, I think Tracy hit the nail on the head, and just to expand on that a little bit, we should have like a common philosophical approach to patient management. And then you could just plug and play. You know, if the patient has this, whatever the condition is, there's special nuances that you have to do relative to that condition. And but if you go to the orthopedics, they do the exam this way. If you go to neurologics, it happens this way. And it's like, why are they all got to be so different? I mean, it's just, that's such a waste of time, you know, and it's unnecessary, and it doesn't make sense. And that whole training that goes into that, you know, how to do that doesn't make sense. And so I think that's a big portion of the bloat. The other thing is that, and again, this is you said I can be politically incorrect, so this is one of my favorite things to be politically incorrect about, is this tug of war that exists between CAPTE and the programs and really NPTE. I'm sorry, FSBPT. That, you know, FSBPT does this crazy, ridiculous survey every 5 years that is just, and I don't want to go off on a tangent, but it's ridiculous how they get away with this and come up with, you know, basis for an examination that they do that now we take a test, and that's the basis of our board exam. And then the schools then, you know, have to teach the test. And again, the academicians will say, no, we don't teach the test. Yeah, okay. You know, I believe that, you know, of course you teach the test, because if you don't teach the test, then you're going to lose your accreditation. So, you know, yeah. And so something's got to happen, because we keep teaching the garbage, because they do the survey and they collect data on this stuff that's important, that's supposedly important in clinical practice. And then they put that on the test. And then we have to keep teaching that because it's on the test. And it's like, we need to take the two of them and put them in a room together, like take them to Tony's Clam Bar down in the lower, you know, east side of Manhattan, and just stick them in a room and say, look, we're cleaning this up and we're going to get rid of this garbage, and nobody's getting out of here until you get rid of the stupidity that's in there, just because, you know, this catch-22 we're in right now. And that's part of the bloat that exists, that because we just keep on this perpetual hamster wheel, because, you know, the survey and the blah, 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 and it's just crazy. I mean, it's crazy. I don't understand. I really don't understand it. So why can't we figure that out and just get rid of it?
Thank you for that. We are now 1 minute away from our transition point, where you will now have a half hour of Q&A with the panelists. So I guess I'll call on whoever has their hand up at the top of the list, which is Jen Gamboa. And you can please, this is not the time for just comments. We'll have that an hour, 45 minutes of that after the half hour Q&A. This half hour is to direct some questions to our panelists. So please come with a question. Jen.
Thank you. I'm curious about how, and I think that you all have addressed it, but specifically the variation in how students approach, or new grads approach assessment, and how they approach critical thinking or clinical problem solving. My experience is that they do not come with a framework for developing a clinical hypothesis. And so it really doesn't matter what interventions you put in, they're already at tactics when they don't really understand how to develop the problem statement. And I'm curious about what you all think about training that quickly, because that's the thing that takes such a long time. and curious about your experiences with sort of global frameworks for assessment, perhaps even as an example, speaking to the Phil McClure article that was recently published on movement systems and kind of a standardized approach to evaluating all of the components of movement systems that could be applied in each, generally speaking, in each of our practice domains.
Is there anybody who would like to take that? Or did you, Jen, have a specific person?
No, I'm curious, just truly, I mean, I'm curious. Yeah.
I'm going to put my,
Bock could speak to it, but yeah.
I'll put my faculty hat on right now because I'm in the middle of doing this. If I look a little tired, that would be the why. We are using cases as a way to teach. And so about at every 2 weeks, they do a skills check. And then within those skills checks, it's you show up and you get credit for being there. And then you learn from each other's experiences. We do 2 students at a time. And we're asking them clinical reasoning questions. And so they're both learning from each other in real time. And then we'll push that to assessment, where at the midterm, they will do an individualized simulated case on one of the musculoskeletal topics and one of the neurological topics, for which is currently the focus of this semester. But my role is to drive complexity in the musculoskeletal cases right now. And so I'm driving concepts related to osteoporosis, pinea, things related to medical screening, safety, when would you refer out? And so those pieces are being built in an integrative fashion across our curriculum in order to try to drive that, taking your clinical reasoning and how do you differentiate something, or how did you know what was the source of that symptom? What test did you choose to do? And asking that question so that it's forcing them to think on their feet, but it's in a low stakes environment for which there's, until they get to midterm or the final performance assessment, they're just learning how to do the process. They're just learning the process. So that's how we're trying to tackle this in our curriculum. And it's really exhausting and fun.
Yeah. Yeah. Well, and I think the concept of iterative is so important, because no one always gets the hypothesis right the first time out of the gate. I mean, and so this idea of iteration, I think, is really important too, because I find students come to the table, they want to be right. Because if they're wrong, then they feel like they're not competent. You're like, that's not the competency we need. We need the iterative curiosity. That's it.
Christin?
From a student perspective, this comes up actually a lot with some of my classmates, is we are there to learn and we should be okay with getting things wrong. So I think a lot of times the whole process of like, we need to be correct, we need to get the score to pass the skills check, we need this, obviously we do need to pass. Yes, I love that idea of what you just discussed, how you like get to do that with another classmate. We did that a couple times throughout our curriculum, and yes, mine's hybrid. So we were only together once a month for 4 days out of the month for 3 years straight. But even during those skills checks, we put so much pressure on ourselves to where the point of, if you fail, we don't feel like we're learning from it because it's such a negative thing. And at the faculty at my program, everyone's really great. But I think a lot of the times it's just, as students, we're very hard on ourselves. And I can actually, Dr. B was actually my original director years ago. And I remember at my orientation, she said, like, PT students are some of the hardest students on themselves, above medical students, like any other program that's along the way. So I just feel like we need, as students, we need to be okay with being wrong, and we need to be told that it's okay, and not get put down for it. So I guess if that kind of helps any of you along the way, because I think that's what makes it the most hard, because we are very, we want this score to pass, and I want my GPA up here. Yes, we're told, don't worry about that so much once you get here, but most of the students are accepted in these programs, you want to have that drive, right? Like that's why you're accepting us into the program. So I stress myself out trying to get that GPA just to get that grade point average award. And it's just caused a lot of, like I said, health problems along the way actually for me. So I want students to be able to just be comfortable with getting it wrong and then being able to learn from it more appropriately.
Christin, that's such a valuable perspective. You know, how important it is to create a culture where we learn from mistakes, where faculty model that, where we're really addressing the stress, low stakes versus high stakes, what's in the pedagogy that gives people the opportunity for iterative learning, and learning from mistakes along the way. We have a bunch of hands up. I'm sorry, I shouldn't have elaborated. Susie, next. You're still on mute, Susie.
Alrighty. I remain interested in the bloat concept, and what I'm hearing are some fabulous ideas about what should be done rather than what shouldn't be done, except for the first point, which I turned into, if it isn't connected to safety in some way and movement in some way, then it could be part of bloat. But that's as far as I've gotten in my list. So I thought it would be useful to ask again, somebody, what shouldn't we be doing? What could we take out? Because we're worried about that. Tracy, can you help?
So there we go. I was having trouble unmuting. So that's a funny thing that you asked, because I remember during COVID, we were working in small groups, and I said to a student, I have this sensation that I have to tell you everything that's in my head right now because I only have this much time with you. And the student said, I'll never remember it. And I was like, that is a really good lesson learned from someone who's, like a clinical expert who is trying to impart all this knowledge and all this information. And I think it's a reflective process that the faculty has to do. You have to be honest with with what you're trying to accomplish with the students, and really try to get your activities into more of an active learning platform, so for which that they can go and look at the detail, and then the key points that you really want them to do to understand that you're sampling in an active learning way. Because that's, I think Christin maybe said it, she learned the best with her hands-on experiences. And I've heard the students say this over and over again, they love the labs that we're doing because it's the hands-on experience that they're remembering. They remember it if they can physically move and do the activities that are incorporated into the concepts. And so I think it's a how can we take the detail, put it into a case-specific activity that they can learn the key components of what they have to walk away from, like safety with gait, how to transfer someone out of bed when they've had abdominal surgery. These components go across clinical practice guidelines. So if I teach it from the perspective of C-section, or that it was just, that someone had their colon resected, it doesn't matter. It's that they had abdominal surgery. What are the things that they need to know for that? So kind of thinking of it more in that, the integrative case pieces, taking the detail out of the lecture, putting it in the case is my thought.
Thank you. Shall we go on to Ellen, or did someone else want to answer that question? Because that was my original question too. What should we be taking out of these floated curriculums?
Can I add a different perspective from less of a content and more of a delivery aspect? And this is something that as a resident, I am allowed to kind of co-teach the musculoskeletal lab portion. And I think that what we found, there was a little bit of an experience in a couple of the labs, specifically the ones that I ran, in that I kind of prefaced the students at the beginning that I wouldn't be calling on people who raise their hands to answer questions. I was just going to be kind of selecting students at random, more as an exercise in getting them to be comfortable with being uncomfortable. We had a lot of students in the program who were very hesitant to answer questions, who I think, like Christin, have this very kind of adverse feeling to feeling like a failure, right? All of us don't want to look silly, but a lot of times in physical therapy, we live in that gray area and we're wrong a lot. And what we want students to be is better at being wrong and kind of adapting from that. And so I think what we cannot do, I guess to get to Susie's question, is allow students to kind of just sit back and passively absorb information, and really challenge them to be put on the spot, to be uncomfortable, because when you get into clinical experiences, you're going to be uncomfortable. And if you've had that experience in a classroom setting already, you're more likely to be successful in that moment. And so less of a content and more of a delivery. And I'm sure that all of you who have much better education in the educational aspect of physical therapy can debate me or tell me I'm very wrong. But I think that for me, it would have been more helpful to be made more comfortable with the uncomfortable just through the curriculum.
Thank you, Chase. Ellen.
Okay, so I have a quick comment relative to what Chase and Christin were talking about with this need to be right. I think if we can help students understand this fall forward framework, you know, every mistake you make is a learning opportunity to get better. And this morning I talked about our faculty really trying to adopt this performance mindset where it's not just about yourself, it's goal-directed behavior, but it's to accomplish something bigger for society. It's not about the grade on the test, it's about getting the patient better. It's about maximizing your input, your impact, and really trying to work on that. And if we can shift away from this performance and maybe look a little bit more at purpose of where we want to go, maybe that is part of the driving force of transitioning us to something which I think, you know, really does involve this level of residency education to be able to deliver the best care. Now, while we all have physical therapist license that allows us to practice across different settings and with populations, just because we could does not mean we should. And I think we really need to take an honest look and say that without the proper skill set tooling, retooling that comes along with that, just because you can treat these individuals, maybe you shouldn't. So that brings me to my question for Bob and Robert, which really is, we have a lot of students, you know, graduating nationally who are recognizing, who are reflective learners and saying, I don't feel ready for this yet, and are going into residency education to fill gaps of maybe what the curriculum should have done. And I am interested in your thoughts on, is that okay? Where is that line? Maybe the line, maybe that old bar of where you start residency education has to go a little bit lower if we consider entry level and intermediate step towards something else. And so I'm wondering your thoughts on what that product looks like when we can't give them all of the experiences. They don't get that dream internship that they want, and they're not feeling comfortable in ortho or sports. And they're going into a residency saying, I need more mentorship than what I would be able to get with on-the-job training.
Well, if I may, there are two ways to look at that. You can learn and not be in a formal residency program. You can get a job with some folks that are qualified clinically to share thought process and algorithms in addressing musculoskeletal problems without being in a formal residency program. So the suggestion that I would have for somebody is get a good job. Don't go after the highest paying job, but go after the one that's going to give you the foundation to enhance your skill sets. As much as I believe in residency training, it doesn't always have to go that way. You can be an extremely competent clinician by simply doing an internship informal with an excellent clinician that can show you the ropes, and you can do the reading. The books are the same. The procedures are the same. The algorithms of managing the healing tissue matrix and prescription of exercise is going to be the same outside of a formal residency program. So I think the situation to fill the gap for that person is to make sure that they're careful as to what job they select. And as they initially embark on the first 1 to 3 years, I have recent graduates give me a 1 and 3 year plan on where they want to be clinically, so that they can develop a skill set that they can take with them anywhere.
Thank you. Kim.
Do you want me to respond to that?
Oh, sorry, Bob.
Because I think I have a little bit different take than Rob, and I, you know, Rob's been a good close friend and mentor of mine for a long time, but I think what he's described is more of a hypothetical model that, yes, hypothetically, could that happen? Probably. But the reality is that, you know, I always tell students, they say, well, what question should I ask on my interview? And one of the things I say you have to ask is, do you have a mentoring program? Do you provide mentoring? And everybody will always say, oh, yeah, of course. Yeah, we do that. And I say, the second question you have to ask is, give me an example of what does that look like? And when was the last time you did that? And what is it going to look like for me? And if they can't answer that question, then you need to walk. And 95% of the time or higher, they're not going to be able to answer it because they have really good intentions. Even the ones that are being genuine and sincere have good intentions, but nobody does it because we're so busy. I mean, in clinical practice right now, we don't even have time to do the things that we really want to do. So there's no way that people have time to really spend a lot of good quality time doing things like mentoring. So outside of a residency where it's built in, where you kind of, in a sense, it's forced, and I don't mean that in a negative way, but it's really just part of the product. And you're getting it, and you're gonna get it, and it's a formal curriculum, and you're gonna get the mentoring. And the other piece that you're going to get is assessment. And you know what? If you got somebody telling you, look, you're going to get tested on that, that makes a huge difference than just taking a bunch of continuing ed or doing a bunch of reading. Because no matter how motivated you are and how much how much you want to learn, you know, taking a test is awfully high motivation. Okay. So I think that philosophically and hypothetically, can somebody do it outside of residency? In the perfect world, there's maybe a possibility, but practically, functionally, I think it's virtually impossible. And we gotta quit thinking that it's okay, because it's not. And then some people asked on the chat, well, it's so hard, and how many graduates do we have, and how many residency slots do we have? Well, you're absolutely right. It's huge. It's a huge difference in terms of what's available, but that's what we have to fix that. That's why we have to put a ton of energy into fixing that and getting it in where it needs to be. And the problem is that we're getting more kickback and fighting from people instead of getting rah, 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 let's do it. We have people fighting and saying, no, we don't need it. Why do we need to do this? And that's the part that's frustrating to me. It's so clear that that's the right path and that's what we need to do. And yes, are there barriers? Absolutely. But you got to start working on them, and you got to start working on them now, or they're never going to, they're never going to get cleared out. So,
Bob, I fully agree with you. But if I didn't supply mentorship to my new clinicians, my business would not continue to grow. I wouldn't be able to sustain it. So yes, it can happen. Is it rare? Yes, it is rare.
Yeah.
But I think it's dangerous to say that it can't happen.
No, I said it's 95%.
Well,
So
it may be even less, it may be even less than that. But if I
Yeah.
don't do that, and the kids don't have to necessarily go through a residency program, and here's my problem with some of them. Some of the residency programs in manual therapy don't have a strong exercise basis.
Yeah.
So I might as well teach them myself. Honestly, I mean, because sometimes folks are taught hands-on techniques and not algorithms in the management of the healing tissue matrix.
Right.
That if you're not a good manual therapist if you don't prescribe exercise. And I was a part of the practice standards committee in the 90s for the definition of manual therapy. We made sure that exercise was in there. So,
Yeah.
it may be rare, but it can happen, at least to get you started. And as the colleague asked, what do they do when they're in the gray area? Well, try to get a decent job. And I fully agree that you need to go through a residency program, hopefully a good one.
Thank you. Lively discussion. Back to questions, Kim.
Yeah, my question is really to Tracy and to the rest of the panelists. You were talking about what your expectations were for new professionals coming in, and it was passion and being open to learning. And Tracy, you had said all except for areas like pediatrics and the ICU, but generally if it's just open to learn and having passion. Can you all comment on why do we continue in our DPT clinical education programs require students do certain types of rotations? Like they have to do an inpatient rotation, they have to do an outpatient rotation. Some even go as far as to say ortho rotation or skilled nursing facility. I'm not agreeing either way. I'm just curious as to what do you guys think about why do we continue to have that, and should we?
So where I am, we don't require that you have to have one in every area. So we kind of philosophically changed. I think that the learners are being allowed to choose the environments that they want to go into, which is different maybe than other institutions. So I'm so biased. I don't know about anybody else's. So we'll have to ask other people on the call.
Jace mentioned this as well. Anyone else want to respond to Kim's question?
I can go ahead. No, go ahead, Kristen. You can give a response first. That's fine.
Mine'll be quick. Kind of like what I said earlier. I think a lot of students don't know what they don't know. I've encountered a lot of male therapists that never thought they'd enjoy pediatrics, but they had a pediatric rotation. I love the idea of letting the student maybe guide themselves into like some of the different areas instead of having strictly this, and this, but we only get one specialty rotation. And that's kind of sometimes it's like, well, maybe I did want to do a pediatric and pelvic, or, so I think as a student perspective, I think there should still be some guidelines as far as, specifically different things, but then more input on the student instead of like, if you really have no desire for inpatient, I guess, like I said, I didn't think I did, but then I had my inpatient rotation and I absolutely loved it. I would never have thought that I would have ever loved it. So I guess it's kind of hard. It just depends on the student too. So I guess if you have a student that like is strictly like, no, I really want to just do this, then maybe I guess we do need to tailor it to that. Like they were talking about earlier, 3 orthopedics, because they know that's what they want. And now they're going to be more advanced in that when they come out. So I guess it's all dependent on the student. And right now, I don't think we're very per student. It's just a global, like these are the requirements right now. So.
Yeah, I was just going to comment, if you look at it from a CAPT perspective, breadth and depth of clinical experiences across all of the areas, I think is the way that element is written. And that can look different for every school. So it kind of goes back to our whole theme of unwarranted variation. But we also, I appreciate Kristen's opinion of, tailoring it to the student. What do you want to get out of your physical therapy academia into your clinical practice? And to do all of that, the capacity of the clinical education system and how we do that is the next step in tackling that big elephant in the room. But does it need to be kind of blown up a little bit? Probably.
Yeah, I would agree. I think it may need to be blown up a little bit, and breadth and depth but we've been talking about competencies. So are they in opposition to each other? Can students learn and learn those competencies in any environment that is structured to provide that training for the students?
I think well-written competencies could do that.
Yes,
Definitely. Absolutely.
Exactly.
Yeah.
So if there's, across the board entrustable activities that all students have to have, then regardless of the environment that they're working in, they should be able to achieve those. And so if the curriculum is written that way, so that you have to know how to take someone's blood pressure, it doesn't matter what environment that you're doing it in.
Exactly.
Thank you. We have 2 more questions in our last 4 minutes of the Q&A. So I'm going to move to Mark.
I'll try to be brief and quick. This question is for Chase, Brian, and Christin. So I first of all, I want to thank you as young clinicians or soon-to-be young clinicians for taking the time to be with us today. And I'm very interested in your perspectives. One of the things we talked about yesterday and this morning is the whole idea that we should begin with the end in mind. When we start our curriculum, we should have a sense of what the outcomes. I'm curious, I'm going to put you on the spot. Did you have a sense of what your program outcomes were when you started? And now that you're either ended or close to the end, do you have a sense of if those were achieved for you personally?
Brian, Chase.
Yeah, I can go and kick it off. I knew I chose the program that I wanted to go to based on largely the how well do our students pass the test kind of at the end of it, right? That is, a big piece of when you're choosing, at least in my thought process, a big piece of why I would want to go somewhere is so that I can be successful. And when you don't know anything, that pass rate on the MPTE is kind of the big, at least for me, the big deciding factor, right? I don't know the intricacies of physical therapy, education, and curricular bloat, and all of the things that we're talking about now as an undergraduate looking to get into a PT program. And so is the second part of your question, did that happen? Well, obviously, yes, I passed my test. But I think that if there are things that we need to better highlight as far as this is what you're going to get out of this, I don't know specifically that I was kind of shown what those were prior to my joining the profession as a student.
Yeah, to piggy off Chase, I think going into PT school, I didn't really have many specific thoughts. Like I chose the program I went to because of the community aspect and just what I heard about the faculty in terms of just the relationship with students. And so I feel, and Chase mentioned this earlier, one of the things that kind of stood out for me that a professor said early on, like in the first week of PT school, was to make yourself uncomfortable. And that's something that I never did in undergrad. And so that really transformed my PT school experience and allowed me to, I feel like, get more from it than I probably would have elsewhere. And so I guess I never really had specific program outcomes. Like you knew you needed to pass the classes, pass the test, and get into the real world and keep learning. So I don't know if I had that specifically in mind, but looking back, I don't think there's anything that I could have changed in that. From an 8 months perspective. Ask me in a year maybe, but
Christin, did you want to answer?
Yes, really quickly. I'm kind of on the same lines as the other two. I chose my program based on what they had to allow me to continue with my life. Kind of already mentioned, it was really tailored to people that still needed to work full time, had kids. That was my number one reason why I chose this specific program. And yes, it did allow me to do all those things. And I loved that part of it. I guess as far as the angle of the curriculum, I don't know if they really specifically said this is what you're going to come out, but it was more of an expectation of what I had. Well, I feel like I also looked at accreditations, obviously, because I was not going to go to a school that wasn't accredited. That was just my choice, of course. But other than that, I went into it expecting to come out as a competent clinician and be ready to work once I graduated. And I'm very confident that I am. I was already in a clinic setting. Like I said, I'm older. I've been in the workforce more than a lot of, traditional DPT students. So I'm very confident in what I can do. I've held a lot of leadership positions within my program because I did put myself out there. I told myself, I want to get as much out of this program as I can. So I feel like if students aren't willing to do that, then they're not going to get out what they could get out of it. You have to put yourself out there. So I think that falls on the student, not always on the program, because there's a lot of opportunities within programs for students to get involved, but it's their choice on whether they do get involved. But yeah, no, I think my program definitely, yes, what they said that I would be able to do during these 4 years, I definitely was able to, and I do appreciate that. So
we're moving to the next phase of open discussion where everyone gets to be a panelist, but I saw Teresa had her hand up and she disappeared from my.
I do, but knowing we had to go to the next phase, I can just wait, so.
You should still get to be first.
Okay, all right, thanks.
Right? So don't put your hand down because then I can't find you. But are you stopping the recording or do you want to record her question, Greg?
I will stop.